This is part 2 of the spinal cord injury, and we're talking about the pediatric side of it. So now we're going to go on to the nursing care of the child with the spinal cord injury. Make sure that the spine is immobilized before any attempt is made to move. We have to assess the airway. We may have to intubate the child without hyperextending the neck. We have to check for circulation. We have to check heart rate. We have to check blood pressure. We have to check for hypovolemia or neurological shock. Bradycardia, hypothermia can also occur. So we also need to do a neurological assessment, which includes evaluating mobility, sensation, and reflexes. The nurse considers the suspected level of spinal cord injury and whether the injury is thought to be either complete or incomplete. As you know, the neurological assessment is going to be ongoing and carefully documented throughout. We also want to assess for and evaluate any other areas of trauma and the impact of the spinal cord injury, such as on the genitourinary system, GI system, or their skin. So our nursing diagnoses are ineffective breathing pattern related to weakness or paralysis of those respiratory muscles after spinal cord injury, risk for skin impairment related to immobility, anxiety related to having a child with an acute condition, interrupted family process related to having a child with an acute and chronic or chronic injury, and impaired physical mobility related to neuromuscular impairment. So on our interventions, the goal is to minimize the potential for further injury, prevent the sequelae of immobility, promote maximal spinal cord recovery. Very important. We talked about the tongs and the halo traction, and that child can remain in that for several weeks. Remember that a child or an adult who is immobilized and neurologically impaired is at risk for respiratory complications as a result of muscle weakness and immobility. So we need to make sure that we assess respiratory status. Pulse ox readings are recorded. These patients are in ICU, of course, and recorded every 1 to 2 hours. Nebulizers, incentive spirometers, intermittent positive pressure breathing are administered as ordered. Some children will need a tracheostomy for prolonged mechanical ventilation, especially if the respiratory muscles are involved. So we also need to evaluate perfusion and neurological integrity. We monitor sensation, we monitor movement, we monitor vital signs, minimum of every hour. Their core body temperature, I and O is very important. Vasopressors can also can be used and are often required for cervical spine injuries. So we also need to reposition the child every 1 to 2 hours, inspect the skin, any pressure areas. The child probably will have an indwelling urinary catheter, so we need to make sure that they're avoiding at least a minimum of 30 mLs per hour. The child, like this child here, has an NG tube placed usually with maybe gravity drainage or low intermittent suction. You have to maintain the patency of that. Make sure that you usually these children are very, very prone to stress ulcers, so they'll be on some kind of antihistamine, histamine blocker, antihistamine, or an antacid. A bowel regimen is usually indicated. We want to prevent impaction. Bowel training includes ingestion of high fiber diet, stool softeners, increased water intake. Caloric intake is very important, and just knowing from psychosocial how dramatic this is to the family and to the patient. So we're going to always support our families. Usually our children are then transferred to a rehab unit for ongoing therapy and teaching, in preparation for that child, hopefully to go home. So we're going to evaluate all our body functions: respiratory, elimination, muscle strength. We're going to check this child's skin. Is it free from breakdown? We're going to allow the parents and the child to verbalize feelings and emotions about the injury and the prognosis of. And we're going to make sure that hopefully the child's neurological function will improve by day, which it usually does. It can go from weeks, months to years that they will and can show improvement. We're going to talk a little bit about autonomic dysreflexia and the therapeutic management of that, and we'll do that on Wednesday. But if you'll read up on that, and I also have a concept map that I'll put on Blackboard for you, just to kind of break it down and what it exactly does. Okay, thanks. Now we're going to be talking about pediatric spinal cord injuries. This starts on page 751 in your PEDS book, and it's very condensed, so it's a very good guideline even for the adult with a spinal cord injury. Spinal cord injuries in children are usually caused by motor vehicle accidents, falls, sports injuries, tumors, congenital abnormalities, gunshot or knife wounds, or attempted suicide. In the infant, a common cause is intentional aggressive shaking by an older person, especially their parents, unfortunately. I brought up this slide because this has the effects of spinal cord injury on the specific level of the spinal cord, such as the cervical. We'll have paralysis of the muscles used for breathing and all of the arm and leg muscles, usually C1 to C5, usually fatal, especially the C1 to C2. C5 to C6, it kind of narrows them down a little bit. The legs are paralyzed, slight ability to flex the arms. C8 to T1, the legs and trunk are paralyzed, the eyelids will droop, the loss of sweating on the forehead, which is also called the Homer's syndrome. Arms relatively normal, hands are paralyzed. Kind of synopses it into the different areas and what the effects are going to be below the area of injury. So I do not want you to memorize this. I just want you to have an overall concept of the effects of the different areas, knowing that the new term for if you have an injury that's high, C1 to C5, that used to be called quadriplegia, now it's called tetraplegia. If it's lower and it causes paraplegia, which would be half the body. And that's that paralysis that's usually from the middle of the trunk down. So when we talk about the incidence of spinal cord injuries, they're less common in children than in adults. With spinal cord injuries, they occur in about 1 to 3% of children who sustain these injuries. Most of the injuries that occur in children occur in that cervical spine between the occiput and C6. Young children are more susceptible to upper spinal cord injury because of the head size is larger. in relation to their body size. And as the child grows older, the likelihood of the spinal cord injury moves, of course, distally. 75% of children who sustain spinal cord injuries from motor vehicle accidents were not wearing seat belts at the time. Now we're going to talk a little bit about the signs and symptoms of spinal cord injury. And those signs and symptoms include loss of some or all of the movement or sensation below the level of injury, such as respiratory depression or apnea, hypotension, bradycardia, hypothermia, and neck pain as well. They vary with the level of injury as to whether the spinal cord injury is complete or incomplete. And if it's complete, the cord is completely severed and there's no spinal intervention is present below that injury. For example, with a complete injury at the C2 level, the child is apneic and requires ventilator support. With an incomplete, the cord has some function remaining below that level of injury. Basically, on the diagnostic eval, the nurse takes the history of the injury, performs a complete neurological exam. The extent is usually determined by an MRI. And it's important to remember that the extent of the motor or sensory deficit may resolve somewhat as the spinal shock resolves, and that's usually within the first 24 hours. Now we're going to talk a little bit about the therapeutic management of the patient that has a spinal cord injury. Treatment includes immobilization and steroid therapy. Those are the two main things. You can maintain immobilization by traction, and those are the tongs that can be used. As you can see, the tongs are connected to the scalp of the head, and they have traction, usually around 40 pounds here for an adult. It would be less, and it would be ordered by the physician. And also halo traction braces. The biggest thing with traction and stabilization is that you make sure that you do not pull on any of the traction when you want to turn the patient, when you want to move the patient. Make sure that you do not pull or use the halo as a brace to reposition patients or to get them in a different position, or in helping them with repositioning. So also you need to make sure that you look at the insertion sites of the halo and of the tongs to make sure that it's clean, free of debris. Usually they have some kind of protocol to clean the site with normal saline and maybe applying some Neosporin ointment to the site as well. So in our nursing care, we want to make sure that